Welcome to Talking Tech Journeys, hosted by me, Ben Whiteley of BPM Tech. We're delighted to bring you season 1 of Talking Tech Journeys. The aim is clear, to bring you some of the most engaging and respected figures within tech and transformation, providing a snapshot of their journeys to share knowledge, ideas and insights on all things tech and transformation. Sit back, relax and enjoy the journey. Hi, welcome to Talking Tech Journeys. I'm Ben Whiteley and I'm delighted to be joined by Taz Aldawoud, founder and CEO of Doc Abode, who provide intelligent and flexible workforce management software for healthcare organisations. The vision is to develop innovative solutions to support the NHS workforce of the future, transforming healthcare delivery to meet increasing demand and complex needs of patients. If that's not enough, Taz is a practicing NHS GP. He's passionate about ensuring the NHS has a sustainable future and that they tackle health inequalities head on. He believes that a human-centered approach to technology will go a long way to achieving this. Really looking forward to exploring this further, Taz. Thanks for joining. How are things?
Thanks, Ben. Good morning. Thanks for having me, first of all. Really excited to be joining you. Yeah, really, so much to talk about, such little time. Really keen to support clinical entrepreneurs, really. People who are at the front line, who get it, who see the problem, and just need to know kind of what to do with next steps. Because I always say ideas are cheap. Everyone's got a great idea. What do you do about it? And how do you keep going? And how do you make sure, you can make something that works in a really tough, but really satisfying way in the NHS?
Good. Well, you're in the right podcast. So yeah, we'll come on to all of that and more, no doubt. So let's dive straight in then, Taz. So just taking you back, how, why, when did you sort of first become interested in health and technology?
I've always been a bit of a sort of tech geek and love digital, to be honest, and I'm interested in business. So I'll be honest, the very first time I really knew I want to do technology is early on in my career. While I was doing my GP training, I also did an MBA, and on that MBA, we got to basically do it with other people from other industries, and the person I got teamed up with was a guy called Adam who had a telemedicine business. Now this was, this was 15 plus years ago. Wow. So I learned a lot about telemedicine, and his customers was the NHS. And I visited him during my MBA as well and learned a lot. And at that point, obviously, as my business skills improved, and I started understanding around telemedicine and telehealth. That's kind of when I first started getting really interested, thinking, yeah, I think this could really help the NHS. And then the rest was history. I got more and more into that. My career evolved, and led to kind of where I am today.
Yes, I mean, telehealth sort of 15 years ago was probably a very different place to where it is now. But
well, you say that, but actually, not that much has moved on,
right?
In my opinion.
Yeah.
And I could probably go into that, but a lot in terms of, there's definitely a lot more enthusiasm now.
Yes.
And COVID allowed the kind of the expansion of things like remote monitoring. I mean, telehealth is an umbrella sort of term, but things like remote monitoring, virtual consultations, they've obviously taken off. Lots of new technologies, and new exciting technologies in that area. But ultimately, it's proactive care. So
I suppose the adoption, but no, good stuff. So just in terms of, obviously, your NHS background, obviously we touched on, the NHS sort of GP, your training. So it'd just be great just to sort of discover your journey a bit more. How did it start? And you're still there now, so.
I mean, I originally went into neurosurgery, and was kind of in that surgical field, and that's what I really wanted to do. And then the more and more kind of business oriented I became, I felt that GP was the best route. So I ended up going through that route, and was in an amazing practice when I was a full-time GP in Bradford, in Homewood, which is quite a deprived area, but kind of people are kind of, salt of the earth sort of people.
Mm.
And it was an amazing time really learning from the really, really experienced GPs around me. But I guess my big break came when I joined an organization, a West Yorkshire organization called Local Care Direct. You probably haven't heard of them
No.
because they brand, they're a social enterprise.
Okay.
They actually run all the GP out of hours contract.
Okay.
And they've been
Right.
doing
Yeah.
that since, well, 15 plus years.
Mm.
And they took me on really early stage. I just got my MBA. My alternative career was just become a GP partner,
Sure.
and that was always attractive.
Mm.
But actually, I took a risk and they took a risk, and they allowed me to basically innovate within that organization. So they're covering almost 2.5 million people,
Wow.
covering 21 different treatment centers, like
Mm.
hundreds of doctors and nurses work for them. They're a big organization. And all you see them as a patient is, once you call 111 and then you
Yeah.
have to see or speak to a doctor or nurse or healthcare professional. And they really gave me the opportunity to kind of, expand my wings really. And I got to sort of use some of my MBA skills, and they supported me. And when I started taking on other roles, so I started that job in 2011.
Yeah.
And then around 2014, the
Mm.
NHS structure changed where they wanted GPs to basically from PCTs to CCGs.
Mm-hmm.
And that's when I joined the Bradford CCG. And so as a commissioner, so I was working as
Right. Yeah.
in a provider company, then joined as a commissioner.
Mm.
Same week I joined the CCG, I joined the NHS England team
Right. Okay.
in their digital, I think it's digital transformation team. But it was an amazing time, and
Mm.
for about 6 years, I was working sort of GP as a director of the urgent care provider,
Mm-hmm.
as a commissioner on the board, and as in a national role. And so I had a really amazing, insightful, and a privileged position to see the whole NHS chain,
Yeah.
how it worked and how it didn't work.
Yeah.
And at that point, exactly, when I founded Doc Abode, I was working pretty much a day a week for all those organizations and as a GP.
Yeah.
And that's when I actually, and I don't know if you know this, but the company name was named after a family mentor of mine,
Okay.
who sadly passed away, but he gave me the motivation to basically set up Doc Abode.
Wow.
And his name was Dr. Taz Aldawoud, or Abode in English. And
Brilliant.
he ran and founded a company called Autocab based in Manchester,
Mm-hmm.
became global, eventually got bought out by Uber. But he
Wow.
brought me in and he showed me how they do it in the taxi world. And I was like, we can do some of this in the NHS, bits
Wow.
of this. And so I think the year after he passed away is when I founded Doc Abode and named it after him. And it was all about
Brilliant.
GPs and home visiting. And I
Amazing.
pitched my idea to all these organizations I was working for.
Yeah.
And they were like, look, we're going to support you, Taz, but we've got your day a week. So crack on with your day job.
Yeah.
Doc Abode will take 5 years to realize. And yeah, they were right.
Yeah.
It took even longer. But but it was Local Care Direct who supported me, who became effectively the early adopter of Doc Abode and helped design it, because it was initially designed for the out of hours market.
Right.
With issues recruiting, retaining GPs and things like that.
Yeah.
And I still remember when we pitched for some Innovate UK funding. It was something called SBRI, Small Business Research Initiative. It's still going now. Georgina Haslam was the chair of LCD board, and she was really unwell that day.
Right.
And we had to go to London to do this pitch to SBRI. And bless her, she came, she supported me. We were successful. And we basically then had that pump prime funding, which was great as a founder, because you knew that, after you spend whatever money you can and time, and I didn't have any more cash to put in, basically. We needed that pump priming, and most people end up getting investment, angels or VCs.
Sure.
Well, we were lucky enough to win SBRI, and there's phase 1 and phase 2.
Wow.
And ultimately that gave us the money to build out an enterprise platform. Took way longer than it took, but it also gave the scrutiny, because when you get that much public funding, you need independent real world evaluations, you need health economic assessment. These are all the things the NHS love. So very early on, that was a great place to be, and we trialed it in West Yorkshire, and then ultimately it got very real when we made our first sale, which was the end of 2019. And by the end of 2019, we had a commercial product. It was all geared towards GPs and out of hours and health visits and things like that. Right. And we made the sale. We started deployment. 3 months later, COVID hit. And at that point, if it wasn't COVID, that was like priority number one. So if your solution didn't help with COVID, nobody was interested. So I had a product and a business that had a market that was really, really keen to adopt this nationally. Because lots of organizations were interested. We had an order book up and down the country. Suddenly we had nothing. And so as any good entrepreneur would do, and I guess being clinical, could see that there was a problem that needed fixing in COVID. And it's a very specific niche problem. But it was a really important problem around the most vulnerable people. It was all the highest priority for the COVID, which was the housebound, the ones in care homes, housebound, extremely vulnerable. They were finding it difficult to get a vaccine because they couldn't get to vaccination centres. So you saw all these numbers going up. We've got 95% of the population vaccinated, but they were struggling to vaccinate the housebound because logistics was so difficult. So we ended up fixing that problem in a very forward-thinking and innovative trust in North London.
Right.
And I mention them now because they've been they were and still continue to be an amazing partner. And they're called Central and Northwest London NHS Foundation Trust. They gave us a break to say, well, we're doing this on behalf of the GPs. Can you help us do the scheduling around COVID vaccinations? And we went, well, here's our current platform. What tweaks do we need to make? And that was released in April 21. And that was around the dose 2, the second dose of the vaccines were due then. And that basically revolutionized how they did their vaccinations. Their productivity improved. And they basically then believed, almost the opposite of what a lot of software vendors do. They kind of promise the earth and unfortunately don't deliver. So I was constantly saying, realistically, this is what we can do. Here's the scope of what we can do. And we delivered, and we over delivered. And we then helped them with co-administration with other vaccine, flu and other things. And that gave us a real high integrity within this trust. And they're a huge trust. And their very cynical nurse at the time, a lady called Lisa Bassi, she'd been through loads of different softwares over her time. And she went, Taz, you proved yourself. You've delivered. Can you look at some of our other services? And that's where we started with all my urgent care background and looking at what community trust had to do. We then, and it was like a mutual agreement to say, why don't we focus this on your out-hospital pathways? And at the time, urgent community response was the out-hospital pathway that had just gone live in 2021. And effectively, it was pretty similar to the use case we're doing in out of hours. When a referral comes through, whether it's 999, 111, a GP or the patient carer, if it's accepted, they then have to deploy a community-based workforce out in the field to see that patient within 2 hours to prevent an unnecessary hospital admission. And also take referrals from hospitals to support an early supported discharge. Excuse me. So when we then designed it with them, launched it, again, it was very, very well and quickly adopted. And basically, it doubled their productivity, reduced their agency staffing costs, and very quickly it spread across that organization. And then they signed a deal with us. And that was really our biggest pivot. And
I was gonna say there's probably quite a few lessons from that story in 100%. Terms of, your primary motivator, your why, but also then, like I say, the partnership with an early adopter. Obviously, COVID happens, the pivot that you guys have obviously, and the need. The pain that needs sort of serving, which is probably a story in itself. So in terms of just taking it back a step, I know we had the brief introduction of Doc Abode and who you are and what you're about, but are you able to just sort of elaborate and put a bit more meat on the bones as to who you are and sort of some of the problems that you've solved but are now solving, and like you say, how the market has maybe sort of changed and pushed you from one direction to another? You've given some really good sort of relevant examples there with COVID and out hospital pathways.
So I guess I've come from a clinical, obviously as a doctor,
Sure.
interested in business,
Yeah.
working kind of more like an entrepreneur within these different organizations.
Yeah.
CCGs, NHSE, local care directs, all those
Yeah.
ones. And then taking that bold step to become an entrepreneur was something that I de-risked by working alongside my roles, which was a really difficult time in the early days because all of these things were pretty much full-time jobs, and I could do this, evenings and weekends and any other time I had. So it was a real challenge to kind of move from clinical into sort of business and management.
How did you sort of juggle that, and what was the sort of views of the NHS within, in terms of I suppose, like say, an entrepreneur, but then becoming an entrepreneur? What
I mean, I'll tell you what disappointed me when I wanted to do my MBA. The NHS effectively wouldn't sponsor it, right? And on that MBA, there were people from the NHS, Department of Health, fully funded, fully sponsored. So I was putting 30 odd K of my own money. I couldn't afford. I was full time. I had to do it part time, weekends. It took me 4 years. They wouldn't even accept me on the MBA. I had to do a year diploma in fundamentals of senior management because they said, well, as a doctor, you can't do an MBA. So, and then obviously I was next to people who were, I was self-funded, and NHS people were like, why is a doctor doing an MBA?
Yeah.
And so for me, that was like, there's something not quite now, even maybe 10 years after that, they were incorporating MBAs into medical degrees.
Yeah.
So it was, I was a bit ahead of my time. Not many doctors were doing MBAs. And by the way, MBAs don't teach you how to be an entrepreneur at all.
No. Yeah.
They are really for really well-established companies. And they give you obviously an insight and then, for the finances in the company, to strategy, all that sort of stuff. But it allowed me to get that book smart knowledge.
Yeah.
And then apply it to some of these other roles I had to become a bit more street smart. And you need that combination, one or the other. They complemented each other. So I then felt confident enough. And again, through my mentor, Falah, he gave me the confidence to say, Taz, you can do this. And I was lucky because my role was all around innovation and digital. Yes. So I was exposed not just within the UK, but internationally, how people did innovation and technology at scale in healthcare. Yeah. So as part of some of the collaborations and partnerships that we did, I was kind of flown out to loads of different countries and shown how they did things. So I learned how to do it. And then I took that plunge, and effectively you start giving up stable, safe income for,
sure.
I didn't pay myself for 6 years. That's the sort of risk that you take. My wife's an NHS consultant who's not business minded at all. So trying to persuade, taking that safety net away is really, really difficult. So it's kind of, you've got to have confidence. You got to back yourself basically.
Yeah.
But you've then also got to surround yourself by the right mentors and advisors. And there's a lot of armchair critics who've never been a founder who can advise. So, and you will need different people along your journey. And I think for me, it's having strong networks, good relationships with people, figuring out who you can trust. Yeah. Because there are many stories I can tell you about, naively going into situations and basically getting shafted. It gives you a bit of a thicker skin and you start becoming a bit more cynical, but you need to have good people around you because you can't do it alone. And I mean good people by your friends and family need to be supported. If they're not, I can imagine mine have been throughout. So if you didn't have that, and then you didn't have the business and friendships around you, the mentors around you, the different stages of your journey, because you need something at every different stage. I don't know. I wouldn't be here talking to you today as a CEO of Doc Abode.
I know you've sort of touched on, and we've mentioned, you're part of the NHS Innovator Accelerator program, and you've worked and been part of AWS Global Accelerator, Health Innovation Network, etc. So, no doubt that's sort of giving you the some support and influence from, externally, and people have been there, done it, and in a similar sort of situation to yourself. So, I mean, what the sort of the key takeaways and from these sort of programs
for me, I mean, the three that you mentioned are probably the three kind of most prominent and successful ones, where the Health Innovation Network, or previously called the Academic Health Science Networks, they really gave me that opportunity through like a programmed approach very early days. So those people that are still there now, that your Richard Stubbs, Nev Youngs, your Tim East, all those guys, and there are many others, Sophie Bate. There's so many that supported me in my journey very early days, but they wrapped around I mean a tiny bit of cash at the time. I think it was like $5,000. It was they wrapped around three different organizations. One was Medipex, West Yorkshire based, Leeds based company. People like Stephen Taylor Parker, like absolutely solid guy through Medipex, supported me right at the beginning of my journey. Talk about kind of advisors and mentors. He kind of had 5 of his own startups, ex-lawyer, really kind of supported me throughout and still continues to. So they wrapped round very early support, which actually then allowed me to be successful in the SBRI funding that I mentioned earlier.
Yes, yeah.
And then as we grew after the pivot, AWS, obviously our technology is AWS hosted.
Yeah.
We had some fantastic people in AWS, Haxala, Tom Allen, many others who both actually recently just left AWS, but who are amazing people. And they supported us in that Global Accelerator for Workforce. Got to meet some really cool people on that, different technologies, all focused on the same problem that I've kind of been passionate about, which is the workforce. How do we make sure that patient safety, patient outcomes are improved, but without burning out your workforce? So how do you give us the tools to work in the most efficient way? Because the last thing we want is to be held up doing non-value adding things. We want to be helping patients. But most of the time we're kind of doing it with our hands and legs tied behind our back. So how can we, and that some of that frustration with the IT and the systems and processes led me to found Doc Abode. So yeah, working with organizations like that, and then obviously more recently through the National Innovation Accelerator, that has been an absolutely brilliant experience for me personally. Because obviously we've had a lot of pull from the system, working with some of the ICBs and ICSs in North London, and just having the right conversations, right introductions, having that ability to be able to have that backing from the NHS, who have kind of filtered out hundreds of other potential solutions to a dozen. And to be able to have their backing has been absolutely fantastic. So I'm kind of 6+ months into that with the NIA. And people like Jack Porter and Mindy has been absolutely brilliant. But what's been even better has been the people I've met. So the other sort of founding CEOs of other companies. Like just earlier this week, was with a whole bunch of them. Carrie from Get You Better, Pete from Isla, Arden from Thalamos. These are company, and you start, because we're all at different stages of journey. We are that peer-to-peer learning around. Look, you can waste a lot of time talking to people in the NHS who are really enthusiastic, but actually, who gets stuff done? Who are the people to avoid? Who are the organizations that are really entrepreneur friendly, and learning the lessons from each other? So the NIA has brought us together, and some of those organizations I've mentioned are actually much bigger than us, and they've started very successfully. But it's not been without challenge. And what you want to know is, you don't want to be making the mistakes where others can potentially you can learn from. And so we've got to a point, and I want to now support those that are earlier on in the start of their journey, to say, look, this is, this is what happened to us and me personally. You can learn lessons from that, and the more people you talk to that have been through it,
Yeah.
you're going to hopefully learn and not make those same potentially fatal or expensive or time-consuming mistakes.
Yeah.
And here are how we've done it. And so the more you can talk to people that you can share experiences with, that's what the NIA has brought to me and the company. So that's been really valuable. And we're at this pivot point now of kind of going from a startup into scale up into bigger systems like ICSs and regions.
Yes. Yeah.
So there are whole new lessons to learn there.
No, and I think, like I said, that there's a lot of key takeaways and some familiar names and faces, from the NIA, and often it's a very similar sort of story and journey in terms of that sort of collaboration and support, and like you said, everybody's at different stages of their sort of startup scale up, which is no doubt very inspiring and exciting for all, but I think it'd be interesting because I know we've talked a little about community service, and obviously there's a Darzi report released just recently. I read an article that you've mentioned him, Chris Garner, ICB, of NCL. He's sort of talking in terms of the need to tilt towards technology to unlock productivity outside of hospitals. So no doubt this is music to your ears in terms of what Doc Abode can do, and I suppose how can community services and businesses like Doc Abode save the broken NHS?
I mean, absolutely. We were actually NIA brought in a guy called Peter Howard, who actually I think he was the lead author on the Darzi report.
Yeah.
So on Tuesday this week, we had a couple of hours with him, and it was obviously a lot of the stuff that is in there, is exactly where I've shaped Doc Abode in being in urgent care at a hospital. And you don't want to be, nobody wants to be in a hospital if they can be managed safely and appropriately at home, and ideally in a proactive way, so they're not, that sort of urgent need doesn't become an emergency. So it obviously makes sense around the channel shift and moving activity into a hospital. However, and the Darzi report picks up on this, the spending and the activity has gone up exponentially within the acute sector, and they are struggling. They're struggling at the front door, whether it's the emergency departments, the occupancy, the beds, the flow within the hospital. That is such a massive problem, and I think it's great that it's been recognised by Lord Darzi and the people that supported that report, that if you go upstream and support patients right at the very beginning, because I think it's something like over 65-year-olds, I think at least will have one chronic long-term condition. And as you get older, those chronic long-term conditions increase.
Yeah, sure.
Give them the information, the education for self-care is absolutely critical. Now, obviously, when things do deteriorate and you need that other support, well, the more you invest in out of hospital and community and prime, and by community I mean a whole array of health and social care. So it's a holistic view of what the community looks like, and obviously the ambulance services for emergency care, the front door at ED and hospitals, they're absolutely appropriate places for people who need that level of care and attention. But it's obvious that the investment needs to follow from, if you're going to move people out of hospitals, you need to invest in the people, the infrastructure, the tools, the technology in our hospital. And that's where we come in, because if you can't just throw money at the problem. That is not going to work.
No.
Even if we had the people, and we don't, recruitment retention is a problem in every part of the NHS.
Sure.
Even if we had the people, the processes and inefficiency of how those systems work would be too expensive to manage the capacity without a hospital care. So all we're looking at doing is optimizing the workflow and productivity in our hospital, so more, I guess, direct clinical care time can happen, less downtime in playing around and getting with the systems and processes, and allowing people to coordinate care in the best possible way around the needs of the patient, but without burning out your workforce. And that's a really hard balance to get right. You can't just ask the workforce to do more.
No,
because they're working as hard as they possibly can. People's experience of care, when they actually end up seeing the doctors and nurses, the therapists, everyone in the community, is very, very good.
Yes.
It's the delays, it's the wait, obviously the waiting list. So can we effectively release some bed days? So you mentioned someone like Chris Garner, who's at North Central London ICB, who is absolutely all over this and has made the case within the ICB and the trusts within it to effectively fund an investment to say, you'll meet all your targets and metrics and improve patient outcomes and care if we can move some of this funding activity into the community and allow us to do that through more people, through some enablers. And Doc Abode is just one of those enablers to be able to allow more efficiency, more productivity, safety for both staff and patients. These are at the heart of why I created Doc Abode. They are absolutely fundamental to creating a sustainable NHS. We are out there to save lives, to allow our NHS customers to save lives by improving their productivity, their efficiency, the sustainability, because without that, our staff are just not going to be able to keep going. And patients will ultimately end in a very high acuity pathway, either to an ambulance or the front door of emergency department. And that is not a good thing for anyone.
No, like I said, I think it's sort of a critical time for the NHS, and obviously that the reports for a 10-year plan to sort of revitalise the health service, and as before, there's so many systemic issues with the staff morale, rising demand, productivity, even sort of austerity, social factors. So I think everybody's sort of pulling together to make a better sort of NHS. But like I say, there's probably a lot of challenges and obstacles and things that you will see from even your practicing GP sort of time, where it's just always very challenging and dynamic environment, I suppose, isn't it?
And absolutely, Ben. One of the key things is no organization can do it alone.
No.
And we've all been set up. The NHS has been set up in a very siloed way. Now that's siloed from an organizational perspective. From professional level as well. There's a lot of professional bodies set up. Take the title away from someone, look at their skill sets and competencies, match that with what patients need, take down those organizational silos, work as a fluid NHS. And that's really difficult because most systems and processes aren't set up to work, even between your own teams and departments. Even if within an organization, there's very little visibility. All we do at Doc Abode is we expose the availability and capacity, not only within your own organization, but other organizations. And we allow that cross-working, that cross-boundary, cross-organizational working. So whether that's calling upon a therapist, a mental health worker, social worker, whoever it needs, it's matching the patient requirement with the right member of staff in a really efficient way. And currently it's very inefficient. And the NHS is really good at using whatever tools it has at its disposal. So if it's got a system, it will either layer multiple ways, typically manual ways of working. Excel, Word, document, bits of paper, whiteboards. Use the system for something it wasn't really intended to be used for. And those layers create inefficiencies. And as you add more demand into those, so if you just put all that capacity and throw it into an inefficient system, they break, and it exposes that inefficiency even more. And that's when people are working very hard, very hard, burning out, but not working smart. So can we get to a point where we give them the right tools to work smart, to be able to absorb this channel shift of activity out of the acute sector, to be able to work holistically in and out of hospital setting, along these care pathways, like discharge to assess, urgent community response, virtual ward, same-day emergency care. I can list the different. We're involved in about a dozen different pathways.
Yeah.
It doesn't really matter what the name of the pathway is.
No,
Is
sure.
it supporting
Yeah.
staff? Is it supporting the right person for that patient at that time of need to keep them at a hospital? And can we just shorten some of the processes in that pathway in a really easy way to implement? Because you can't have something that's so complex and you're asking for a complete redesign of things. It's got to be really easy, really quick, and it's got to make things easier to do for the frontline staff, and it's got to seamlessly happen. So our experience in doing that, obviously having deployed across many boroughs, even within London itself, many boroughs there, different teams, about a dozen different pathways. There's a lot of trial and error.
Yeah.
Every organization is different, and most NHS organizations will say, and sometimes the excuse is, well, I know that worked there, but it won't work for us because of these reasons.
Yeah.
So you need to have enough experience to recognize, well, we know that we can mitigate that by doing this, and so to be able to have that frontline knowledge and actually designing it with people who have experienced care, the people delivering care. If you haven't done that design at the grassroots, you're just another bit of kit that probably is going to sit on a shelf, and that's no good for the system, the public taxpayer, or technology companies, because we'd get a bad rep if some other technology is not utilized. It affects everyone.
Yeah. I mean, look, we could probably talk for days about this. There's quite a few issues that we've probably not touched on today, but like I said, I think it's all about the holistic view, incremental, small steps, and everybody trying to work for the good of patient care, and like I said, playing their part. But look, Taz, I mean, many thanks for your time today, and obviously. It's great to explore the work you've done down at Doc Abode and some of the issues in terms of, your entrepreneurship, and pivoting along the way. So thanks for your time.
Thank you, Ben, for having me, and it's been a pleasure. Thank you.